Hello, class. This is Mrs. Alston, and we're going to finish up our radiation protection. This is going to be Unit 4, Chapters 10, 11, 12, and 15. Chapter 10 starts on page 175. So the agenda that we will be covering will be radiation protection standard organizations, U.S. regulatory agencies, radiation safety program, radiation-induced responses of concern in radiation protection, current radiation protection philosophy, basis for effective dose limiting systems, and the NCRP. So looking at our radiation protection standard organizations, they begin on page 175. So the ICRP, or the International Commission on Radiologic Protection, it gives the standards for the safe uses of ionizing radiation. It provides clear recommendations for consistent radiation protection, and it recommends both the public and the occupational dose limits. The NCRP, or the National Council on Radiation Protection and Measurement, reviews the recommendations from the ICRP, and then it takes that data and applies it to the policies created for radiation protection in the United States. It is not an enforceable agency, however, but the federal and state agencies are left to enforce the recommendations and policies from the NCRP. Now, you need to know the 102 report and 116 report for the registry. Our U.S. regulatory agencies are the NRC, which is the federal agency that controls the possession, use, and protection of atomic energy, and it oversees the nuclear energy industry. The FDA, which is the Food and Drug Administration, and they actually regulates the design and manufacturing of X-ray equipment. And the FDA conducts on-site inspections. They ensure the standards for public and occupational workers are being met. And then we have OSHA, which is the Occupational Safety and Health Administration, and they regulate occupational exposure to radiation. They ensure employees have the right to know about the hazards within their work environment. We're now going to look at the Radiation Safety Program Review, which is on page 179. Now, you recall that ALARA was once called Optimization for Radiation Protection, or ORP. You have a Radiation Safety Committee and a Radiation Safety Officer, also known as the RSO, who maintains the policies and makes sure that everybody is following that radiation safety program. So all facilities who utilize radiation must have a program. The NRC mandates that there is a committee and a safety officer, and the RSO is required to oversee the daily operations of the program and also prepare for the yearly review from the FDA. So question, what is something else the RSO would do if the need arose? Speak with employees who become pregnant and declare their pregnancy. So we cannot assume that anybody's pregnant. They have to actually declare that they are pregnant. Another question, what report number does ALARA come from? That's the NCRP report number 160. So on page 181, the ALARA translates into the equivalent dose and the effective dose, ensuring they remain well below the established guidelines. Remember in chapter 8 and 9, we discussed the radiation-induced responses. Tissue reactions are somatic effects or effects on the person being irradiated. This is a threshold response. So studies have shown that people can have some dose without demonstrating a biological effect from it. Tissue reactions usually only occur when there has been a high enough dose of radiation to produce that reaction. But there are cases where tissue reactions take years to show up. This would be when the tissue has been given low doses of radiation over several years, and that is what we as radiologic technologists need to be concerned about. So you can review that on page 183, the early and the late tissue reactions. Stochastic effects are the non-threshold and occur randomly in nature. However, radiation exposure can increase the chances of obtaining that effect. Those are cancer and genetic alterations. They can be seen in both linear and linear quadratic dose curves. Now, the current radiation protection philosophy, if you look at page 183, remember that in previous readings that the effective dose was created to assist with the understanding and reduction of somatic and genetic effects. So that's based on the linear non-threshold dose curve. So any dose of radiation has the potential for causing biological damage to either the person receiving it or their offspring. So who does the effective dose attempt to protect? That would be the occupational workers and the general public, basically anyone who's coming into contact with radiation. Further on page 183, we can look at the effective dose limit, or EDL. So the EDL gives us the upper boundaries of a dose that could be given, in theory, without any harmful effects to the person receiving it. It can be given as a whole body or a partial body dose. These effective dose limits are set for both public and workers. The body parts may have varying dose limits due to their radiosensitivity. An occupational risk is said to be 2.5% chance of fatal accident over your career. So you only have a 2.5% if you are working around radiation, having some sort of fatal accident occur. When we look at page 185, the NCRP proposes the dose total external and internal cumulative dose to be no greater than the worker's age times 10 millisieverts for the effective dose. So say if somebody is 30, their total dose for both internal and external should not exceed 30 millisieverts for the effective dose. So when is the most significant risk for radiation-induced intellectual disability? That would be between the weeks of 8 to 15 weeks after conception, because they're still highly radiosensitive at that point because they're rapidly dividing, making that fetus. Continuing on with the dose effective limiting system, the context for radiation protection states that any organ is vulnerable to biological damage due to radiation. And remember, the tissue weighting factor is also the effective dose, and that's an attempt to equate various risks of cancer and genetic effects to the area being exposed. The tissues and the organs have different levels of sensitivity to radiation, and the tissue weighting factor looks at the ratio of risk when the whole body is uniformly irradiated, and that is the study under the NCRP number 116, which has now been updated to the NCRP number 184. So if you look on page 185, box 10.7, the worker's cumulative effective dose cannot be greater than an individual's dose of age times 10 millisieverts. On page 186, the effective dose limits for public is 1 millisievert for infrequent exposure and a limit of 5 millisieverts. And then on page 189, for the pregnant worker, the monthly equivalent dose should not exceed 0.5 millisieverts per month, with a maximum of 5 millisieverts throughout the entire gestational or 9-month period. Then finally, review page 191, box 10.3. The lens of the eye has 150 millisievert threshold occupational and 500 millisieverts for the hands, feet, and skin because they're more radio resistant. So that is the amount of dose that we should not be exceeding. So if you wanted to further look of things that would help to reduce the dose, in your imaging production book on page 812, it talks about dose limiting instead of holding the IR. You can use the IR holder. You can have an adult relative or friend hold the IR while shielded. Non-radiographer healthcare workers can hold, and non-reproductive radiographers can also hold. So those are other ways that we can limit the dose to us as the RT working around radiation quite frequently. So that is the general overview of chapter 10. Make sure that you are reading all the pages that were assigned for this course. We're now going to move on to chapter 11. Chapter 11 talks about the equipment design for radiation protection. It starts on page 194 and goes through page 224. So for this, we're going to talk about radiation safety features of the equipment and radiation features with the fluoro unit. So starting on page 195, with the X-ray tube, the tube housing is constructed with lead lining to reduce radiation leakage. The measurement at a distance of 1 meter from the X-ray source cannot exceed 0.88 milligrays per hour. For the control panel, which is on page 196, it must have a lead-lined window for visualization of your patient. The exposure button must be fixed so that the RT cannot move around the control booth barrier during exposure. And then for your skin distance from the collimators, that's on page 198 and page 206. For stationary equipment, the patient's skin dose to the collimator must be at least 15 centimeters or 6 inches below. And for portable equipment, the patient's skin surface to the collimator must be at least 30 centimeters or 12 inches below the collimator. So let's do a little bit of review. What would be used to measure any leakage radiation coming from the tube housing? Do you remember our meters that we had? That would be the cutie pie. The filtration of the X-ray beam totals about 1.5 millimeters of aluminum equivalency for the stationary units, and you can find that on page 201. Mobile units require a minimum of 2.5 millimeters of aluminum equivalency, and that's on page 202 in box 11.2. The grids increase the patient's dose, but the benefit of the quality of the image outweighs the increased dose. And then look at page 198 for skin sparing. So with skin sparing, that is to minimize skin exposure to electrons produced by photon interaction with the collimator. And that's when we said that the patient's skin surface should be at least 15 centimeters below the collimator. So that's where I got the information for your skin distance from the collimator. When we look at fluoroscopic equipment, that's going to be on page 12. Starting there, your image intensifier allows the radiologist to reduce the patient dose by increasing the overall brightness and the visibility of the organ detail. And then the pulse fluoro, that replaces the real-time fluoro. The pulse fluoro is intermittent live exposure, and that helps to reduce the dose to the patient while still allowing the operator to be able to see some sort of live or real-time radiation images. So on page 212, the fluoro produces the largest amount of dose to the patient and potentially to the RT. Of course, it's going to be giving the patient the dose through what type of interaction? That would be photoelectric. And the reaction that or interaction that we would have as an RT would be Compton. Some of the units will have remote control systems so the personnel can stand outside of the X-ray room and speak over an intercom. Now that could only be done if our patient was well enough to be able to follow instructions without the need of assistance from any imaging personnel. The Bucky slot cover has to be 0.25 millimeters of lead, and the protective curtain that hangs down from the image intensifier has to be 0.25 millimeters of lead. The fluoro tower is required to have equivalent shielding of 2 millimeters of lead, and that is considered a primary barrier. You can also look at page 811 in your imaging procedures book. So some safety features of fluoroscopic equipment. There needs to be a dead man switch, which means that if your foot is taken off, the fluoro is automatically discontinued. It needs to have a cumulative audible 5-minute timer so that everybody knows how long live radiation has been going off with people in the room. As I said, the Bucky slot cover should be 0.25 millimeters of lead. The protective drape or sliding panel needs to be 2.25 millimeters of lead. Any mobile barrier needs to be 2 millimeters of lead equivalency. 2.5 millimeters of aluminum must be in the direct path of the useful beam, and 3 millimeters is ideal. The maximum entrance skin dose or rate should not exceed 88 milligrams in air per minute, and the FDA mandates 10 Roentgens per minute for entrance skin dose rate. So if you look on page 307, fluoro and C-arm can have a dose rate for personnel of several milligrams per hour. Portable and fixed C-arm should have the X-ray tube under the patient for less radiation dose to the X-ray personnel. So that concludes chapter 11. Make sure that you are reading the pages that were outlined in your reading requirements. And now we're going to move on to chapter 12. So as I stated earlier, your stationary fixed fluoroscopes is on page 215. And the source to skin distance should not be closer than 38 centimeters or 15 inches. And for mobile fluoroscopy or C-arm, which is on page 217, the source to skin or distance should not be more than 30 centimeters or 12 inches. We're now going to move on to chapter 12, which is management of patient radiation dose during X-ray procedures. That begins on page 229 of your book. So the agenda for chapter 12 is going to be effective communication, protective shielding, technique charts, repeat imaging, concern about risk of exposure during diagnostic imaging procedures, fluoroscopic guided positioning, protecting the pregnant or potentially pregnant patient, pediatric considerations during radiographic imaging. Now, effective communication is on page 229, and that is just a review of chapter 1, talking to your patient, making sure that you have the right verbal messages and body language. You learned all of this in patient care. We know that communication is the best way to avoid repeats to ensure that our patient is understanding what we need from them. Now, this next slide is talking about protective shielding and the changes that we are starting to undergo with our shielding. So on page 231, shields are designed to remove radiation dose to areas outside the field of interest and hope to reduce the chance of biological damage. So let's take a look at this video. So that discussed why some places that you go to clinic has decided to remove the shield from the gonadal area because they believe now that scatter will be trapped within the body instead of exiting the body. So question, what is the first step to reduce excessive radiation dose around the part of interest? That would be collimation. So go back and look at page 232. Collimation is your number one defender against unnecessary radiation to another body part outside of what we're interested in looking at. Next, we're going to look at technique charts, which are on page 233. Because the DR plates can now adjust and correct the resultant image of overexposure or dose creep, it is more important than ever for RTs to follow an approved technique chart whenever using fixed techniques. And the use of air gap techniques also help to reduce that. So repeat radiographic images are on page 235. The DR should have reduced the number of repeats due to the fact that the majority of the repeats were due to technical factors. However, positioning errors have now risen. Some of the RTs are not positioning well enough because it's quicker to continue to redo until it is acceptable, or for those RTs that expect perfection at the expense of their patient. Many perfectionistic RTs will continue to perform repeats even when the first image was in an acceptable range to produce a diagnosis. So remember, there's a difference between optimal and diagnostic. Okay, so if you still have a diagnostic quality image, this isn't about you and your ego. It's about what is best for the patient. And remember, you're dealing with radiation, which could cause cancer or genetic mutations on a um, unborn fetus. So we do not want to be doing that just because you um, want to have the perfect image, which is highly unlikely because there's always room for improvement. So we're going to look at the concern about risk of exposure during diagnostic imaging procedures. So the skin dose uses the TLD dosimeter and it calculates the dose to the epidermis, looking at the entrance skin dose. So that would be if the RT is dealing with a lot of radiation that they have to handle. The gonadal dose is looking at the dose to the gonadal area, and female gonads receive about 3 times more radiation dose than males. Do you know why? Obviously, because the female gonadal reproductive organs are within the pelvic region, while the males sit below the symphysis pubis, so we can usually collimate it out of the area of interest. Genetically significant dose. The equivalent dose is the dose to the gonadal area, and the genetically significant dose for the US is approximately 0.2 millisieverts. The bone marrow dose is the one of great importance because remember, the bone marrow and lymphocytes are going to be highly radiosensitive. So looking on page 237, I have a question for you. What 3 ways can we describe the amount of radiation the patient received during an X-ray? That would be number 1, the entrance skin dose or ESE, 2, the bone marrow dose, or 3, the gonadal dose. If you look on page 238, the genetically significant dose or GSD is used for defining the equivalent dose on a population. So question, why is the bone marrow dose the most important? Because it contains a large number of precursor cells and can cause leukemia. Moving on to page 239, we're going to look at the fluoroscopic guided positioning. So RTs would use this to help guide them to the anatomical structures prior to taking the X-ray. And what do you think this violates? We're going to talk about that in class. I want you to think about it and you come back to class and tell me if you've listened to this prior to us meeting on this chapter. But studies have shown that the use of fluoroscopic guidance increases entrance skin dose. Positioning the patient utilizing the skills taught to you is the best policy versus using some sort of guide that takes radiation to find where you'd like to go. Protecting the pregnant or potentially pregnant patient. So on page 240, the NCRP suggests only getting x-rays after the first few days after the onset of menstruation to be safe. So that is the 10-day rule. The dose below 0.2 gray shows that damage to a newborn is unlikely. However, it cannot be excluded. Most diagnostic procedures other than fluor are usually below 0.1 gray. So we are generally safe, but there is no absolute guarantee other than not getting radiated at all. On page 244, when we're looking at pediatric considerations during radiographic imaging, radiation-induced leukemia is 2 times more likely than adult patients. Why? Look at page 245 and we can discuss that in class. Motion is a factor of the increased dose when we're talking about pediatric patients. So what we can do as RTs to reduce the chance of motion is to use appropriate immobilization devices, comforting the patient, making sure that they feel safe and secure, and reducing the time as much as possible on your control panel. Collimation will reduce irradiation to unnecessary areas, so no chabdomens. So we're now moving on to chapter 15, our last chapter of the course. So this one talks about management of imaging personnel and the radiation dose, and it starts on page 293. So what we're going to be talking about is the annual limits for occupationally exposed personnel, dose reducing techniques, protection for pregnant personnel, basic principles of radiation protection for personnel exposure reduction, protection during fluoroscopic procedures, protection during mobile X-ray examinations, protection during C-arm fluoroscopy, and diagnostic X-ray suite protection design. So the effective dose limits are going to be on page 294. The NCRP is the annual occupational effective dose, or EFD, of 50 millisieverts to the whole body. So that is under the NCRP's recommendations of what is going to be the amount that would be safe for workers to be able to receive without any potential effects. Compton scatter, reducing this by utilizing any means that reduces scatter being produced, because you know that that is going to protect us as RTs, because that's where we get our radiation dose from, is from Compton scatter. And then wearing protective apparel is also going to help. So 0.25 millimeters of lead is the minimum for the lower KVP range. So when we're wearing the aprons, it needs to be 0.25 as a minimum. However, 0.5 is the most common because that can be used for the higher KVP, for fluoro work, and for OR. So instead of most departments having the 0.25 and the 0.5, they'll just purchase the 0.5. So be careful with that question. If it says, what is the minimum dose or the minimum amount of lead, that answers 0.25. But if they're talking about the most common, the general, what's used for higher KVs, what's used for fluoro, what's used for portable or OR work, that's always 0.5. Okay, so 0.5 is your standard, but the minimum is 0.25. So on page 294, the effective dose for RTs does not include personal medical exposures or natural background. So when we're talking about our effective dose, we do not take into account what everybody else would also be exposed to. We're only talking about from our jobs. So question, the lifetime dose is how much? It should not exceed 10 times the age of the patient or 10 times the age of the RT. Another question, what is the most effective way for reducing dose to occupational workers? You should know this one. It's the ALARA concept, time, distance, and shielding. How can we reduce Compton scatter? We can use automatic collimation. We can restrict the margin of light to the inside of the IR. We can filter the beam to exclude the low energy photons. We can wear protective aprons when in the room during exposures, fluoroscopy, and mobile studies. So when we're looking at our shields, as we put them away, we should never keep them folded because that could cause cracks, which would allow scatter to pass through those cracks. And the RT should never stand in the primary beam to restrain a patient, always stand at 90-degree angle. For the work schedules, RTs should be rotated through the various areas within the imaging department so that no one person is receiving an excessive amount of dose. So for those departments who keep their people up in the OR all the time or on portables all the time, that's really a no-no because they are receiving a higher dose than the rest of the RTs that work in that area because they're not having to be in the operating room like the specified or the dedicated OR techs. So protecting the pregnant personnel, the pregnant RT, first of all, It has to be voluntary disclosure, and this is on page 298. Has to be on voluntary disclosure that the RT is pregnant, and then they will meet with the RSO, which will put a plan in place. 2 dosimeters will be required at that point, one measuring the RT and one measuring the unborn fetus. The second dosimeter will be worn at the waist underneath any aprons to see if any radiation is passing through the apron, which might potentially hit the fetus. So the equivalent dose for the fetus should not exceed 0.5 millisieverts per month, with a total of 5 millisieverts for the total gestational period. And the pregnant RT must wear a wraparound apron of 0.5 millimeters of lead equivalency, and that's according to the NCRP. We don't penalize others by removing the pregnant worker out of regular assignments, okay? So we can't make other RTs work in areas where the pregnant RT would work simply because they're pregnant. So as I said, we're going to have a second badge under the apron at the waist level, and we're going to limit performing high dose procedures if at all possible, but we're not going to make other people have to pick up that slack on a regular basis, because that would start to affect their potential dose. Now, moving on to structural design, this is going to be on page 301. Most common barriers that we have are going to be made of either lead or concrete, and accessory protective devices are made of lead impregnated vinyl, such as the aprons, the gloves, the shields, and the eyeglasses. There are to be used in addition to or when not able to be behind the stationary or movable protective barrier. So if you're going up on a portable or you're in fluoro or something of that nature and you do not have that primary barrier, then you could use those along with your distance to help reduce the amount of radiation you're being exposed to. The design of the X-ray department and rooms is for the protection of the general public, the patients, and imaging personnel. So when we're looking at how the rooms are built, the primary barriers are those that are in the path of the direct X-ray beam. So say the wall right behind the wall bucky, that's a primary barrier because the X-ray tube is facing that wall. These contain 1.6 millimeters or 1/16th of an inch of lead, and they need to extend from the floor by 2.1 meters or 7 feet upward. The secondary barriers should have an overlap over the primary of 1.3 centimeters or 1/2 of an inch and extend the rest of the way up to the ceiling. They are 0.8 millimeters or 1/32 inch of lead, and they are for any leakage radiation or scatter radiation that may be coming out of either the patient or the X-ray tube. Exposures should always be made with the doors closed to reduce the chance of anyone outside the room getting exposed, unless you have a built-in one as we do in the lab, where you have to go around that corner. The control booth extends 2.1 meters or about 7 feet upward. It should be permanently secured to the floor, and X-rays should scatter 2 times before reaching any area behind that wall. So question, do you think the control booth is considered a primary or secondary barrier? It should be considered a secondary barrier because the X-ray tube should never face the control booth. So when you are positioning your patient, you don't ever want to have to turn your X-ray tube to where it would be facing the control panel or have the beam coming out towards the control panel. That's on page 303. The control booth window is impregnated with 1.5 millimeters or 1/16 inch of lead equivalent. And the RT should not be exposed to 1 millisievert per week when standing behind that control panel. The exposure switch behind the control panel should be mounted to the wall so that no one is able to remove it and walk around that protective barrier. Additional shielding, that's going to be on page 303. You can have clear secondary acrylic barriers, and they should have about 30% of lead by weight. They should be SATR resistant, extend 2.1 millimeters up, 2.1 meters up, and can be available anywhere from 0.3 to millimeters of lead equivalent. There can also be clear overhead barriers, usually used in the cath lab, and they have to have a 0.5 millimeters of lead equivalency. Fluoroscopic protection, which is on 305, is what we're going to be talking about next. Now, we've already talked about protective aprons, thyroid shields, lead-lined gloves for the radiologist, and the goggles. Remember, the lead apron must be 0.5 millimeters of lead equivalency if you're under fluoro procedures. So, question, what type of lead apron is preferred while in the fluoro room? That would be a wraparound so you can turn your back without the person who is operating the fluoro unit having to stop until you turn back around again. So there are other means that help to reduce radiation dose. They are the beam collimation, added filtration, control of the exposures, the appropriate source to skin distance, and the protective housing. Now, the federal government also requires that there be a cumulative timer of 5 minutes with an audible alarm. And the source to skin distance for a fixed fluoroscopic unit is 38 centimeters or about 15 inches. A remote control system helps also to reduce the dose, so if you could use one, that is also recommended. The protective curtain coming off the image intensifier should be a minimum of 0.25 millimeters of lead and should not be removed. The Bucky slot cover is 0.25 millimeters of lead. So what is the benefit of that? It protects whoever is standing near the table at the gonadal area. So with the rotation of the RTs, proper rotation out of those areas where the RTs need to remain during exposures will reduce our exposure dose. Next, we're going to talk about mobile protection, and that's on page 306. And remember, ALARA is your time, distance, and shielding. So that's the number one safety mechanism that we have to protect ourselves when doing mobile procedures. So we need to have a protective apron, and that should be assigned on the attached portable unit. So each unit is recommended that it has a assigned apron attached to that portable unit so you do not have to go grab one, although that is not usually how it is done. Newer versions of the portables will have remote control exposure buttons to allow the RT to move even further away than the 6 feet of recommended distance. If there is not a remote exposure button, the cord must be at least 6 feet to move away as far as possible. This allows the RT to stand 1, away from the patient, 2, away from the X-ray tube, and 3, away from the useful beam. So question, compared to standing at right angles if in the room versus moving 6 feet away, which is more beneficial to the RT? Obviously, your distance is going to be your best bet, so moving 6 feet away is the best answer. The next thing that we're going to be talking about is C-arm protection, and this is going to be on page 307. So we need to be more aware of radiation safety when using the C-arm. The patterns of use are unpredictable due to the physicians requesting specific images. They are not as trained as radiologists or RTs are, so we need to help educate those who are not normally in the use of radiation practices. C-arm machines and fluoro are typically comparable, giving out several milligray in air per hour. The exposure to the RT comes from the scatter like it does in fluoro. The exposure rate caused by scatter near the entrance surface of the patient on the tube side exceeds the exposure rate near the exit surface or your image intensifier. The scatter is different by a factor of 2 to 3 times. So question, where would the best place for the RT to be during the cross-table hip? On the image intensifier side. Note on page 308, it states that 0.5 millimeters of lead is required for both the apron and the thyroid shield. So another question, where is the X-ray tube and image intensifier placed for best protection? The tube should be under the patient. It should always be under the patient because that is going to give us the most radiation protection from what is being emitted because you have the lead skirts. You also have your full apron that is covering from your gonadal up. If the tube was on top, then you would have your head, the lens of your eyes, your thyroid all exposed to that radiation coming out. So what helps reduce dose with the C-arm? You want to 1, move away from the C-arm. 2, wear appropriate shields. 3, have the X-ray tube under the table. 4, use the last image hold button. 5, bring the image intensifier as close as possible because it can also act as a scatter barrier. 6, collimate down to the smallest area possible because this also reduces scatter. 7, ensure good positioning, centering, proper positioning prior to making the exposure. 8, use the foot pedal or remote exposure button to be able to back away further from the C-arm and the patient. 9, reduce the use of mag mode because that only increases the MA, which increases the dose and possibility of scatter. And 10, use the use of pulse mode when possible. The NCRP recommends the dose to the hands to be 500 millisieverts. And once again, what is the minimum source to skin distance for mobile C-arms? That would be 30 centimeters or 12 inches. Now, as far as your accessory shields go, you have aprons, gloves, thyroid shields, skull caps, and eyewear. Now, the apron, as I said earlier, is 0.25 millimeters of lead minimum with 0.5 millimeters of lead preferred. Your gloves are going to be 0.25 millimeters of lead. The thyroid is 0.5 millimeters of lead, and the eyeglasses are 0.35 millimeters of lead. On page 311, you need to be aware of how to work the workload and the inverse square law and the use factor. So talking about controlled versus uncontrolled areas, this is going to be on page 312 to 315. So we're going to be calculating barrier shielding requirements, current approaches to shielding, and radiation caution signs. So the controlled area is the wall that divides the X-ray department and the X-ray room, and it's allowed a 1 millisievert weekly dose. The uncontrolled area is a nearby general public hallway, and it is allowed a weekly dose of this area of 20 microsieverts. So why such a huge difference? Go over page 312 and we'll discuss that in class. All right, so in summary, what we're going to do in class is we're going to list as many dose reducing techniques that you can think of that was gone over in our final chapter 15. So this concludes our final unit number 4 and the final lecture for this course. I thank you very much, and it was a pleasure working with you as always. Thank you.